Hello, and welcome to the VJHemOnc podcast, where we will be sharing some of the key updates in AL amyloidosis from ASH 2025. In this episode, we will cover important developments across the amyloidosis treatment landscape, from updated risk stratification and optimization of frontline therapy to emerging immunotherapies in the relapsed and refractory setting. This podcast is part of the amyloidosis channel on VJHemOnc, which is supported with funding from Prothena. This supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. So, without further ado, let's get started. We begin with one of the most fundamental challenges in amyloidosis today, identifying patients with the highest risk disease in the context of modern therapies. Jahanzaib Khwaja discusses a newly validated staging system designed to better define ultra-high-risk AL amyloidosis in the era of daratumumab-based treatment.
Yeah, so systemic AL amyloidosis has significantly changed over the last years in terms of outcomes for patients. Traditionally, we've used the Mayo 2004, which is modified with the European modification, and then the Mayo 2012 models. And those are really valid and helpful in eras in which we had access to bortezomib and other such agents. We've, however, seen since the introduction of daratumumab, outcomes have significantly improved. And what was considered as traditionally high risk, so those were 3B and Mayo 4 in the traditional models, now no longer identify the poorest risk disease. So the rationale for developing a new staging model, which is the AL-ISS, was that we want to identify the poor risk patients as well as those who will do well. So 3C identifies the poorest risk. So those are with a longitudinal strain of greater or equal to minus 9%, as well as an NT-proBNP of greater or equal to 8,500 and a troponin greater than or equal to 50. And those patients in the modern era perform poorly. We've considered those as an ultra-high risk, and we suggest that these patients should be treated with alternate treatment approaches. So consideration of clinical trial design, particularly for these patients, or novel therapies, or consideration in certain selected cases for cardiac transplantation. So I think there's great relevance for this new prognostic staging model, and I'm hopeful that we'll use this to shape trial design and our management for these patients in the future.
As outcomes improve for many patients, these findings highlight the importance of refining prognostic models to identify those who continue to have poor outcomes and may benefit from alternative treatment strategies or clinical trial enrollment. We next turn to the frontline setting, where optimizing therapy for patients with cardiac involvement remains a key priority. Vaishali Sanchorawala presents results from the Phase II AQUARIUS trial, which evaluated the cardiac safety of 2 daratumumab-VCd dosing schedules in newly diagnosed AL amyloidosis.
I presented the Phase II data of AQUARIUS study on Sunday evening session in the AL amyloidosis session. Phase II AQUARIUS study was designed to evaluate cardiac safety and characterize cardiac events in patients with cardiac involvement from AL amyloidosis newly diagnosed setting. And this is a follow-up study to Andromeda clinical trial, which is a study, as a reminder, of daratumumab, cyclophosphamide, bortezomib, and dexamethasone, or dara-VCd, which led to significantly higher hematologic responses, organ responses, major organ deterioration, progression-free survival, and overall survival in comparison with VCD alone, leading to its approval by the regulatory agencies in the treatment of AL amyloidosis. So in the Phase II AQUARIUS study, the primary objectives were to assess and characterize cardiac events with 2 different treatment schedules of dara-VCD, and also to look at the pharmacokinetics of this particular regimen in minority patients. And patients with newly diagnosed AL amyloidosis were enrolled on this clinical trial. In cohort 1 of that clinical trial, all patients had to have cardiac involvement, and they were randomized to 2-1. The Arm A of cohort 1 was the standard treatment, just exactly same as Andromeda, the treatment regimen, treatment schedule. VCD was administered concurrently with daratumumab, and this is referred as dara immediate VCD. The intervention arm was B of cohort 1, in which VCD was administered after 3 cycles of daratumumab, and this was called dara-deferred VCD. In arm 2, patients with minority were enrolled and they received dara-immediate VCD. Overall, 142 patients with cardiac involvement were analyzed in this clinical trial, enrolled in this clinical trial. And again, the median treatment duration was equal in both groups, dara-immediate VCD as well as dara-deferred VCD group at 10.4 cycles. And there were similar amounts of patients, approximately 10%, which discontinued the study in both treatment groups, and majority of the reasons were predominantly due to death. There were 9 treatment emergent deaths. 2 of these deaths occurred within 60 days, and they were both in the dara-immediate VCD group. However, they were attributed not to related to the study treatment, but to cardiac amyloidosis. Now, going on to cardiac events, the cardiac safety events, treatment emergent adverse events, were approximately 46% for patients who were treated with dara-immediate VCD, and they occurred more frequently in cycles 1 to 3. Whereas in contrast, cardiac events occurred at 61% in dara-deferred VCD group, and they predominantly occurred in cycles 4 to 6. Again, as a reminder, VCD was added at cycle 4 in dara-deferred VCD group. Most of these adverse events were related to patients who had higher baseline Mayo Stage 3 disease, regardless of the treatment group. And furthermore, there was an adjudication committee, which was an independent adjudication committee that looked at about 38 events in 20 patients, and most of these events were related to underlying cardiac amyloidosis. We also noted that patients who developed major cardiac events had worse baseline cardiac risk profile than those who did not develop major cardiac events. Hematologic complete response was 59% in patients who were treated on dara-deferred VCD versus 62% for patients treated with dara-immediate VCD. However, time to hematologic complete response was approximately 2 months for dara-immediate VCD and 3 months for dara-deferred VCD. So the median time to response to complete hematologic response was longer for patients on dara-deferred VCD. So again, in this trial, we demonstrated that dara-VCD, whether immediate or deferred, had good safety profile for cardiac involvement patients. Cardiac safety was not a major issue, and also this led to very high hematologic efficacy. So this really corroborates our prior results of Andromeda, that this regimen remains a standard of care for newly diagnosed patients with AL amyloidosis who also have cardiac involvement.
These data reinforce daratumumab plus VCD as a standard of care in newly diagnosed AL amyloidosis, while underscoring the impact of baseline cardiac risk, treatment-related events, and outcomes. Beyond frontline therapy, ASH 2025 highlighted growing momentum behind immunotherapeutic strategies in relapsed and refractory AL amyloidosis, where treatment options remain limited. Vaishali Sanchorawala shares updated results from a Phase I study evaluating the BCMA and CD3-directed bispecific antibody etentamig in patients with relapsed or refractory disease.
Etentamig is a second-generation BCMA-CD3 bispecific antibody, and it is a very, very interesting molecule with dual BCMA binding site, also very low CD3 affinity binding site, and a silenced FC portion, making the half-life of this molecule longer to allow us to dose this medication every 4 weeks. So etentamig was studied in Phase 1b, Phase II schedule for AL amyloidosis in relapsed refractory setting. The data that was presented at this meeting were on 34 patients who were enrolled on Phase 1b dose escalation phase of the study. The doses were 20 milligrams, 40 milligrams, and 60 milligrams, which were administered every 4 weeks. This was a fixed duration treatment schedule of 24 cycles, and 34 patients really had a very high hematologic responses on this schedule. Overall hematologic complete response was 82%, and VGPR was 18%, with an overall response rate of 100% in patients with refractory relapsed AL amyloidosis. This deep hematologic responses occurred at a median of 29 days, so very, very rapid responses, and this led to also organ responses in approximately 50% of patients. Moreover, the safety profile was quite favorable. CRS rate was extremely low, in less than 10%, and grade 3-4 infections occurred in about 1 patient out of 34, that's 2.9%. So, and there were no delayed toxicities as well as no neurotoxicities. So this is a very, very exciting time and very well tolerated bispecific antibody for relapsed AL amyloidosis.
The deep and rapid hematologic responses observed with etentamig alongside a favourable safety profile suggests that bispecific antibodies may play an important role in addressing unmet need in this setting. Another major focus at this year's meeting was the feasibility of CAR T-cell therapy in AL amyloidosis, a setting where no FDA-approved therapies currently exist. Heather Landau discusses initial results from the NEXI-CART-2 trial evaluating the BCMA-directed CAR T-cell therapy NXC201 in patients with relapsed or refractory AL amyloidosis.
The NEXI-CART-2 study is the first trial of a BCMA-directed CAR T-cell in patients with relapsed and refractory AL amyloidosis. That is a patient population that has a true unmet medical need, where there is not a single FDA-approved therapy for that condition. And so what we did is we enrolled patients with at least had 1 line of prior therapy, including an anti-CD38 antibody and a proteasome inhibitor, to this trial that opened in June of 2024. And we are reporting on 20 patients. So they were treated with NXC201, which is a novel BCMA-directed CAR T-cell. And after a dose escalation, we're now in the dose expansion. So 3 patients were treated with a dose of 150 times 10 to the 6 CD CAR T cells, and the rest of the patients with 450 million cells. And amongst the 20 patients who have been treated, the bottom line is over 75% of patients have achieved a complete hematologic response, meaning normalization of their free light chain or paraprotein and immunofixation negative in both the serum and urine. 4 additional patients are MRD negative in the bone marrow, but what we see with this therapy is that there's rapid and prompt reductions of the paraprotein, either particularly the free light chains, but also the M spike, but the immunofixation tends to be positive for a lot longer, such that 4 additional patients are MRD negative in the bone marrow, but have not yet achieved a complete hematologic response based on persistent immunofixation positivity.
These early findings suggest that CAR T-cell therapy can induce deep hematologic responses in selected patients with manageable toxicity and the potential for meaningful disease control. As increasingly potent therapies drive deeper responses, attention is also turning to how best to define and monitor durable disease control. Andrew Staron discusses data showing that sustained MRD negativity, rather than a single MRD assessment, is strongly associated with long-term disease control in AL amyloidosis.
Our study investigates how durability of MRD affects clinical outcomes in patients with AL amyloidosis who already have achieved hematologic complete response by traditional consensus criteria. Even when patients achieve hematologic complete response, small amounts of clonal plasma cells can remain in the bone marrow, and this can lead to future clinical relapse and progression. Using highly sensitive multiparametric flow cytometry, we at the Boston University Amyloidosis Center have been tracking MRD status in real-world clinical settings since 2019. What we really wanted to better understand is whether sustained MRD negativity, meaning having negative MRD results over time, better predicts prognosis as opposed to just a single MRD measurement. We analyzed 106 patients using serial MRD monitoring. Overall, we found that 40% of patients achieved sustained MRD negativity, and this seemed to be true across different treatment history, including patients who were newly diagnosed after first line of treatment, as well as relapsed patients who had received 2 or more lines of therapy. We also saw this across different treatment types, including stem cell transplantation and daratumumab-based treatments. When looking at clinical outcomes, the results were striking. None of the patients who had sustained MRD negativity went on to experience hematologic progression. In contrast, nearly half of patients who had MRD positivity went on to have either hematologic or organ progression. Furthermore, we observed that some patients who were initially MRD negative experienced MRD resurgence, meaning they later went on to test MRD positive. And many of these individuals later had clinical progression, often occurring 1 to 2 years after MRD resurgence. So our study findings show that MRD is dynamic in AL amyloidosis and that a single MRD check is probably not enough. Sustained MRD negativity is a strong marker of long-term disease control. And MRD resurgence may serve as an early warning signal. So in short, serial longitudinal MRD monitoring adds value to post-treatment surveillance in AL amyloidosis, helping us to identify which patients truly have sustained disease control and which patients need closer follow-up monitoring.
These findings position serial MRD monitoring as a valuable tool for post-treatment surveillance and early identification of relapse risk. Finally, real-world evidence is helping clarify how immunotherapies perform outside of clinical trials. Matthew Rees presents multi-center data on BCMA-directed CAR T-cell and bispecific T-cell engager therapies for systemic AL amyloidosis.
I think the basis for this abstract is that we know that obtaining rapid, deep hematologic responses is key to improving organ function and survival outcomes in AL amyloidosis. Although we've seen the introduction of anti-CD38 monoclonal antibodies transform newly diagnosed AL amyloidosis, a significant proportion of patients will respond suboptimally to first-line therapy, that is, not obtaining a complete response, and many others will relapse after obtaining an initial response. We've seen that bispecific T-cell engagers have produced unprecedented outcomes in relapsed myeloma, and so whether these highly active molecules can be safely applied to AL amyloidosis is a key clinical question. Because of this, we undertook a multi-center retrospective study across 9 U.S. academic medical centers, which are a part of the U.S. Multiple Myeloma Immunotherapy Consortium. We included all patients with systemic AL amyloidosis who received a bispecific T-cell engager therapy targeting either the B-cell maturation antigen or the GPRC5D antigen. Between 2023 and 2025, we identified 29 patients who had received this therapy, including 19 patients who received teclistamab, 6 who'd received elranatamab, and 4 who'd received talquetamab. We saw a predominance of lambda light chain isotype in 60% of individuals, and about 30% of individuals had the translocation 1114. Our cohort had a high bone marrow plasma cell burden, with 74% of cases having a plasma cell burden in excess of 10% at diagnosis of their AL amyloidosis. and 34% of patients having either more than 60% bone marrow plasma cells at diagnosis or a free light chain ratio in excess of 100. Our cohort was extensively treated with a median prior lines of 5, and all patients had seen an anti-CD38 monoclonal antibody. We had 2 cases who were stage 3A, according to the European modification of the Mayo 2004 prognostic score, and 19% of patients, or 5 patients, were stage 3B. 66% had cardiac involvement, and 59% had renal involvement. In terms of tolerability, we saw that the rate of cytokine release syndrome of any grade was 45%. There were no grade 3 events, and we saw the rate of ICANS was 14%, and again, there were no grade 3 events. A third of the cohort experienced at least one infection, and 20% of patients experienced a grade 3 or higher infection. In terms of response rates, the overall response rate was 76% by AL amyloidosis response criteria, and the majority of these were deep responses, with 66% of patients obtaining a complete response, which is very impressive given how much prior treatment they had received. We saw that there were 6 deaths during the study period. 3 of these occurred while on TCE therapy. There was an episode of ventricular fibrillation arrest, which occurred during step-up dosing, but was not associated with cytokine release syndrome. There was also 1 death secondary to cardiac failure and 1 death secondary to an infectious complication. There were 3 deaths that occurred off therapy, 1 of unknown etiology, 1 from progressive disease, 1 as a complication of an unrelated surgery. In terms of organ responses, we saw that 64% of people with cardiac involvement obtained a cardiac response, and all patients with renal involvement who were evaluable for assessment obtained a response. So this is actually the largest real-world cohort of bispecific T-cell engager therapy in AL amyloidosis. It shows that this approach to treatment produces a high rate of rapid and deep hematological responses. Despite a high prevalence of cardiac and renal involvement, actually rates of cytokine release syndrome were modest, and importantly, we did not see any grade 3 events. Nonetheless, infectious complications were frequent, including 1 death related to infection. I think although we had a short period of follow-up, these high hematological responses translated to good organ responses, and is encouraging that this therapy could be more broadly adapted in AL amyloidosis. And of course, there's a number of clinical trials that are exploring this question right now. Again, it's paramount in AL amyloidosis to obtain a deep hematological response. This is the only way we presently have to permit organ recovery and improve mortality in this condition. While daratumumab has really transformed the management of newly diagnosed disease, it isn't a complete cure for all patients, and a number of patients will either respond suboptimally or later relapse after treatment with this agent. We know that chimeric antigen receptor T-cell therapy, or CAR T, is a highly active modality in multiple myeloma, where it produces very deep and durable remissions. And so whether this strategy can be safely and effectively adopted in AL amyloidosis, a population where patients will often have concomitant organ dysfunction, is an important unanswered question. So to address this, we undertook a retrospective study of 8 U.S. academic medical centers who were a part of the U.S. Multiple Myeloma Immunotherapy Consortium. We included patients who had a diagnosis of systemic AL amyloidosis who received BCMA-targeted CAR T therapy. All of these patients, importantly, had a concurrent diagnosis of multiple myeloma. Between 2021 and 2025, we identified 33 patients who were treated with CAR T, 9 patients received ide-cel, 24 patients received cilta-cel. The median age of our patients was 69 years, there was a predominance of the kappa light chain isotype, which I think reflects the fact that there was a myeloma flavor to a number of the patients involved. We also saw that all patients had a high plasma cell burden at diagnosis, 88% of individuals having more than 20% bone marrow plasma cells at their initial diagnosis. This cohort was extensively treated. The median number of prior lines was 6, and all patients had had prior CD38 exposure. In terms of organ involvement, we saw 30% of patients had cardiac involvement, or again, 30% had renal involvement, a quarter had gastrointestinal involvement, and around 12% had some form of nervous system involvement. Prior to CAR T therapy, we had incomplete staging information, but we importantly did not have any known cases of stage 3B disease. In terms of cytokine release syndrome and safety, the rate of CRS of any grade was 64%. We saw only 2 cases of grade 3 CRS, no cases of grade 4 CRS. In terms of ICANS, the overall rate of any grade was 15%, and there were only 2 cases of grade 3 ICANS. The rates of CRS were slightly higher with cilta-cel compared to ide-cel, as one might expect, at 67% versus 56%. The median time to CRS also differed between the 2 agents at 1 day for ide-cel, but 6 days for cilta-cel. We did not see any cases of non-ICANS neurotoxicity, and we saw about 30% of individuals have an infection of any grade, but less than 10% of patients had a severe infection, grade 3 or higher. The overall response rate, according to AL amyloidosis criteria, was 91%. The vast majority of these were either very good or complete responses. There were 24 complete responses. Again, these were comparable between the 2 agents, although slightly higher with cilta-cel, where the overall response rate was 96%, compared to ide-cel, where the overall response rate was 78%. In terms of deaths, there were 5 deaths, 3 which were related to the underlying disease, 1 related to an infection associated with IECHS, and 1 which was unrelated. In terms of organ response, we had 7 patients who were eligible for cardiac organ assessment. 3 of them obtained a cardiac response, and 3 patients were eligible for renal organ assessment. Of those, 2 obtained a response. So I think this study shows that commercial BCMA-targeted CAR T therapy induces deep, rapid hematological responses in heavily pre-treated patients with AL amyloidosis and concurrent multiple myeloma. This form of therapy was feasible to administer, the rates of CRS were acceptable, and there were only isolated severe cases of CRS and ICANS. Nearly all of our patients obtained a deep hematological response, and in the patients who were assessable for organ response, this appeared to translate into organ improvement.
These real-world data support the feasibility of delivering immunotherapies in heavily pretreated patients with organ involvement, while highlighting the importance of careful patient selection and monitoring. Thank you for listening. We hope you enjoyed this episode covering key AL amyloidosis highlights from ASH 2025. To explore more expert insights and interviews, head over to VJHemOnc.com for our full ASH 2025 coverage. Be sure to follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple or Podbean. Until next time.